Iridocorneal dysgenesis consists of posterior embryotoxin, Axenfeld-Rieger syndrome, and Peters anomaly and aniridia. So the first one is posterior embryotoxin. It refers to a prominent and anteriorly displaced Schwalbe line. Posterior embryotoxin is seen as a thin grey white arcuate ridge adjacent to the limbus on the inner surface of the cornea. It is an innocuous isolated finding in up to 15% of the general population, but is one of the features of Axenfeld-Rieger anomaly. It is also seen in the multi-system genetic disorder Illegal syndrome, in which optic disc drusen are also common. Axenfeld-Rieger syndrome is the umbrella term for a spectrum of disorders featuring bilateral developmental ocular anomalies. Axenfeld anomaly, Rieger anomaly, and Rieger syndrome. These three are combinedly called Axenfeld-Rieger syndrome. Axenfeld anomaly, Rieger anomaly, and Rieger syndrome. It is caused by defective neural crest cell related processes during fetal development. An abnormal endothelial cell membrane has been identified on anterior segment structures in some patients. The key implication of the syndrome is a 50% risk of glaucoma. Associated variants in several different genes have been found, including PITX2, PAX6, FOXC1, RIG2. That is, different genetic abnormalities can give a similar clinical picture. Cases may be sporadic, but a family history is common. When inheritance is autosomal dominant with variable expressivity but with very high penetrance, there is no gender predilection. Clinical features. First one is Axenfeld anomaly. There is posterior embryotoxin. It is a posterior embryotoxin with attached strands of peripheral iris. The latter best viewed with gonioscopy. Here you can see posterior embryotoxin, and here the peripheral iris is attached to it on gonioscopy. Rieger anomaly often manifests with an anterior segment appearance similar to that of iridocorneal endothelial syndrome, which we have already discussed. So there is posterior embryotoxin, there is iris stromal hypoplasia, there is ectropion, uvea and correctopia, and full thickness iris defects. This picture shows mild iris stromal hypoplasia. This picture shows severe iris stromal hypoplasia. There is full thickness iris hole here, you can see, with correctopia. Gonioscopy in mild cases shows the Axenfeld anomaly. In severe cases, broad leaves of the iris adhere to the cornea anterior to the Schwalbe line, as shown in this picture. Glaucoma develops in about 50%, usually during childhood or early adulthood. Surgical management is often necessary. Rieger syndrome is characterized by Rieger anomaly plus with extraocular malformations. As with the ocular features, they are caused by defective neural crests, cell-related tissue development. There are dental anomalies, hypodontia, which means few teeth, and microdontia, which means small teeth. So here you can see in the pictures. There is facial anomalies, maxillary hypoplasia, broad nasal bridge, telecanthus, hypertelorism. Other anomalies include redundant paraumbilical skin, hypospadias, hearing loss, hydrocephalus, cardiac and renal anomalies. Congenital hip dislocation are rare. Next is Peters anomaly. It is a rare but often severe condition that is bilateral in more than half of cases. It is the result of defective neural crest cell migration during fetal development. Manifestations range from mild to severe. Most cases are sporadic, although autosomal recessive inheritance has been described. Clinical features: there is Peters type 1 and Peters type 2. Type 1 affects the cornea alone. Type 2 shows both cornea and lens abnormality. There is central corneal opacity of variable density. Here you can see central corneal density, corneal opacity and large central opacity. Posterior corneal defect involves posterior stroma, decimate membrane. So the decimate membrane is involved. The endothelium with or without iridocorneal or lenticulocorneal adhesions. As you can see in this picture, there is lenticulocorneal adhesion. Lenticulocorneal adhesion. Glaucoma occurs in about 50% of cases, and due to associated angle anomaly, onset is usually in infancy, but occasionally in childhood or later. The prognosis tends to be worse than in primary congenital glaucoma. The systemic associations include craniofacial and central nervous system anomalies. Peters plus syndrome include a particular constellation of systemic abnormalities. The differential diagnosis includes sclerocornea, tears in decimates membrane, ulcers. U mean ulcer, M means metabolic disorders, P means Peters anomaly, E means endothelial dystrophy, congenital hereditary endothelial dystrophy, posterior polymorphous corneal dystrophy, and D means dermoid. Next is aniridia. It is a rare bilateral condition that may have life-threatening associations. It occurs as a result of abnormal neuroectodermal development secondary to a mutation in the PAX6 gene. This gene is adjacent to gene WT1, mutation of which predisposed to Wilms tumor. There is autosomal dominant type, sporadic type, and Gillespie syndrome. The autosomal dominant type has this aniridia accounts for about 2/3 of cases, has no systemic implications. Penetrance is complete, which means all patients with the genotype will have the phenotype, but expressivity means severity is variable. Sporadic include WARG, W-A-R-G, previously known as Miller syndrome. It includes Wilms tumor. A means aniridia, M means mental retardation, G means genitourinary abnormality. So this is Miller syndrome or WARG. So we should rule out Wilms tumor, mental retardation, and genitourinary abnormalities. In 1/3 of patients, children with sporadic aniridia have about 30% chance of developing Wilms tumor. Gillespie syndrome counts for 1% of cases. Inheritance is autosomal recessive but is not caused by PAX6 mutation. Cerebellar ataxia, learning disabilities are features. Diagnosis: all patients with sporadic aniridia should have abdominal ultrasonography every 3 months until 5 years of age, every 6 months until 10 years of age, and annually until 16 years of age to detect the development of Wilms tumor and until molecular genetic analysis confirms the absence of WT1 mutation. Presentation is typically at birth with nystagmus, photophobia. A parent may have noticed the absence of irides or apparently large pupil. Aniridia is variable in severity ranging from minimal and detectable only by retroillumination and to total absence. So this is picture shows partial aniridia and this picture shows total aniridia. The lids often show meibomian gland dysfunction. Cornea, there is tear film instability, there is dry eye, there may be dry eye, there may be epithelial defects, and limbal stem cell deficiency may result in conjunctivalization of the peripheral cornea. Total corneal central stromal scarring and vascularization may occur in the end stage disease. Scarring and vascularization. Lens changes can include cataract and subluxation, usually superiorly. Fundus possible abnormalities include foveal and or optic nerve hypoplasia and choroidal coloboma. So in this picture you can see optic nerve hypoplasia. Gonioscopy even in eyes with apparently total aniridia usually shows a hypoplastic or rudimentary frill of iris tissue. Rudimentary frill of iris tissue. Here you can see. The glaucoma occurs in 75% of patients, usually presents in late childhood or adolescence. It is caused by synechial angle closure secondary to contraction of rudimentary iris tissue. Treatment is difficult and the prognosis is guarded. Glaucoma is medically treated, but it is usually inadequate. So trabeculectomy with mitomycin C or combined trabeculectomy have been tried in the past but usually fail to control the IOP. Glaucoma drainage devices offer the best chance of long-term successful control of IOP. Diode laser cycloablation may be necessary if other modalities fail. Painted contact lenses may be used to create an artificial pupil and improve both vision and cosmesis. Simple tinted lenses are an alternative. Both may improve nystagmus. Lubricants are frequently required for associated keratopathy. Cataract surgery is often required. A tinted artificial lens implant may be used to try to improve the photophobia. Trauma to the corneal limbus should be minimized in order to preserve stem cell function. Prosthetic iris implantation has been described in pseudophakic aniridic eyes but may be complicated or worsen glaucoma. Limbal stem cell transplantation with or without keratoplasty may be required. Refractive errors in myopia and squint should be managed aggressively. Glaucoma in pacomatosis. Number 1 is Sturge-Weber syndrome, also known as encephalotrigeminal angiomatosis. It is a congenital sporadic pacomatosis. Glaucoma ipsilateral to the facial hemangioma develops in about 30%, and in 60% of these IOP elevation occurs before the age of 2 years. It may result in ophthalmus. Here you can see. In the remainder, glaucoma may develop at any time from infancy to adulthood. The pathogenesis is uncertain, but putative mechanisms include trabecular dysgenesis in infants and raised episcleral venous pressure associated with arteriovenous communication in an episcleral hemangioma in older patients. Medical treatment is inadequate. The goniotomy may be successful in eyes with angle anomalies, and combined trabeculotomy and trabeculectomy gives good results in early onset cases but carries a relatively high risk of choroidal effusion and suprachoroidal hemorrhage. Other surgical options may be utilized. Neurofibromatosis type 1. It is a disorder that primarily affects cell growth of neural tissue. Inheritance is autosomal dominance with irregular penetrance and variable expressivity. Glaucoma is relatively rare and when present usually unilateral and congenital. About 50% of patients with glaucoma have ipsilateral plexiform neurofibroma of the upper lid or facial hemiatrophy. Various mechanisms have been identified including congenital angle anomaly which may be associated with ectropion uvea. This is prosthetic contact lens before. Here you can see an iridia and after implantation. This is an iridia intraocular lens with pigmented optic and large overall diameter. So this is artificial iris. Dr. Lee is one of the first surgeons in the country to be invited to implant the artificial iris implant. It received FDA approval in 2018 and is a custom-made hand-colored prosthesis to treat serious iris defects. This includes full or partial aniridia, such as congenital aniridia, and acquired defects such as trauma or surgery.